Yes, so today I'm going to start on to do endocrine diseases. Remember, this is a series on human pathology, and it's actually a very interesting session because we've already covered 5 sessions: cardiovascular pathology, respiratory pathology, gastrointestinal, diseases of the hepatobiliary system, and also now today we are covering now the endocrine diseases. So that's me. What are we going to cover today? We are going to cover to review the anatomy and physiology of the various endocrine glands, understand some pituitary disorders, thyroid disorders, adrenal disorders, and also diabetes mellitus, and also hyper-stroke hypopituitarism, and also hyper-stroke hypothyroidism. So it's actually going to be a shorter session, about 40 to 1 hour session. So when you talk about endocrine glands, what are we talking about? So endocrine glands are actually ductless glands or ductless organs that secrete hormones directly into the bloodstream. So you have these glands such as the pituitary gland, the thyroid gland here, and the parathyroid, the thymus. You'll have the pancreas and the adrenal glands. So these glands, they produce hormones, then they directly put that their hormones into the bloodstream to regulate metabolism, growth, reproduction, and homeostasis. And here are examples of some of the endocrine glands. We can see pineal gland, the one that regulates the sleep-wake cycle. We can see the hypothalamus. We can appreciate the pituitary gland, the parathyroid glands, the thyroid gland, the thymus, adrenal glands, pancreas, kidneys, testes, and ovaries. So in an exam setting, when I'm now telling you to list examples of endocrine glands, I will expect you to mention about all these. And actually, it can be a question. I can give you maybe a question and maybe tell you to list 3 or 4 or 5 endocrine glands. So in these glands, we can divide them into two. We can divide them into central and peripheral glands. So central glands are usually two, hypothalamus and the hypothalamus and the pituitary gland. And as you can see here, these central glands are found in the brain. So you'll have the hypothalamus and the pituitary gland. They are found in the brain. And the function of the hypothalamus is to integrate neural and endocrine signals, while the pituitary has two parts, adenohypophysis and neurohypophysis. So adenohypophysis, that is the anterior part of the pituitary gland, and then neurohypophysis, that is the posterior part of the pituitary gland. And this pituitary gland is connected to the hypothalamus using this hypothalamic pituitary axis that regulates most of endocrine glands. So most of these peripheral glands are actually regulated by these central glands. So hypothalamus and pituitary glands, they will regulate these other peripheral glands. And now some of the peripheral glands that we look at, for example, thyroid, that is found on the neck, is actually there for metabolism regulation, growth, um, and then parathyroids will be there for calcium metabolism or calcium homeostasis. Then adrenal, they are there for as stress hormones. Then pancreas, now what's part of the pancreas specifically? Remember in our earlier session we covered the exocrine part of the pancreas, but today we are covering now the endocrine part of the pancreas that is called the islands of the Langerhans that enables glucose regulation of glucose homeostasis. So the first thing that I'll check today is actually the pituitary gland. The pituitary gland, just by name itself. So here we have the hypothalamus on either end. Then it descends to give us the pituitary gland. So this pituitary gland, you can see this is a part of the skull, and these are the various cranial nerves, as you can see there. And now, what is the location? So in an exam setting, you can be told if it's anatomy, just remember this is a review of anatomy. So where does this pituitary gland lie? You can appreciate that it lies in the sella tussica. So this bone here is actually the sphenoid bone. So this point is called as sella tussica of the sphenoid bone at the base of the skull. You can see this is now the cerebrum. This is a pituitary gland developing or coming along the fundibulum. So the sella tussica is here and is connected to the brain using the fundibulum. And you can appreciate now anterior to it you'll have also inferior to it you'll have the sphenoid sinus. Lateral to it you'll have the cavernous sinus on either ends. Superiorly you'll have this optic chiasma superiorly. And then apart from having the cavernous sinus being laterally, remember this cavernous sinus will also contain cranial nerve number 3, 4, and branches of cranial nerve number 5 and number 6. That is V1 and V2 and cranial nerve number 6. Also remember also this internal carotid that will be a content of the cavernous sinus, and also it will be found on the superior aspect of the structure. So what will be supplying, I need us to appreciate this image here on our right, that the blood supply of this pituitary gland, you can appreciate this is a infundibulum, this is a pituitary gland, this is a posterior aspect of the pituitary gland, that is the neurohypophysis, anterior part, adenohypophysis. So the anterior part will be supplied by hypophyseal arteries. Hypophyseal arteries. You can see superior hypophyseal artery supplies the hypothalamus and the hypothalamus, and together with its portal system. This portal system is formed by venous connection. Then this hypophyseal portal system carries releasing hormones to the anterior pituitary. So we'll have these hormones being carried to the anterior pituitary, while inferior hypophyseal arteries supplies the posterior pituitary. So what are we taking for in terms of blood supply? Know that superior and inferior hypophyseal arteries supply the pituitary gland. Then in terms of histology, we need to appreciate in terms of histology that anteriorly, the anterior pituitary will have two types of cells. It will have acidophils and basophils. That is in nature of the stain that is taking. So acidophils tend to take acidic stains. Basophils tend to take basic stains. So acidophils, they'll be producing growth hormone and prolactin, while basophils will be producing thyroid stimulating hormone, adrenocorticotropin releasing hormone, and also follicle stimulating hormone and luteinizing hormones. Some of the hormones produced by basophils. While posterior pituitary gland, as you can appreciate, this is a posterior pituitary gland here. It receives, these are nerve fibers from the hypothalamus connecting to store ADH. ADH is antidiuretic hormone and oxytocin. So in an exam setting, I can tell you to describe the cell types that are produced, the cells and the hormones that are produced by the anterior pituitary glands and also by the posterior pituitary glands. So you mentioned the hormones produced and the cells that produces them. So the first pathology that we'll cover today will cover hypopituitarism. So remember, these cells are producing hormones, which are growth hormone, prolactin, thyroid stimulating, and the other hormones. So when you talk about hypo means under secretion. So hypopituitarism is when now one or more pituitary hormones is deficient, is not produced well. And when you have now all the 6 hormones being affected, you'll have panhypopituitarism. Pan means all. So panhypopituitarism, as you can see on this blue image here. So all 6 anterior pituitary hormones are deficient. So what are some of the symptoms that we'll have? The symptoms that you'll have, okay, just to remind us of the hypothalamic hormones are 2. You'll have antidiuretic hormones, that are actually stored by the posterior pituitary. You have antidiuretic hormone and oxytocin. So what causes this hypopituitarism is that you can appreciate the causes. One, if you have tumors of the pituitary gland. So pituitary adenomas, as you can see, they are pituitary adenoma. So this one is a pituitary gland here. This is a hypothalamus. You can see this is a sella tussica. If you have tumors of the pituitary gland, so that's one. Two, if you have tumors of the central nervous system, that is, the brain has tumors that compress the pituitary gland. And then the other type of tumor that we need to know is the craniopharyngiomas. And these craniopharyngiomas are found in children. Once again, they can compress, or actually they are tumors of the pituitary gland. So tumors compress pituitary gland or interfere with blood supply to the pituitary gland. And due to that, issues with pituitary gland. The other one is injury, such as traumatic brain injury, maybe due to road traffic accident. People who undergo radiotherapy, maybe due to cancers, they can easily injure the pituitary gland, and also surgery can injure pituitary glands. Other causes of hypopituitarism is sarcoidosis is a disease, TB meningitis, syphilis, fungal infections, and others such as empty cellular syndrome. That is where now you have CSF compressing. CSF is cerebrospinal fluid compressing the pituitary gland. Another one is Sheehan's syndrome. Sheehan's syndrome occurs after delivery, especially for the pregnant women, where we'll have postpartum hemorrhage. In this postpartum hemorrhage, like there is a lot of loss of blood. There's a lot of blood loss that leads to hypotension and ischemia, and that leads to issues with the pituitary gland being affected. So now we've seen the causes of this hypopituitarism. So tumors, injury, infections, some things like empty cellular syndrome and Sheehan's syndrome. So what now are the features that will present? One, in children, you'll appreciate there will be slow growth and delayed puberty. So secondary sexual characteristics won't be there. There'll be slow growth. In adults, we'll appreciate there'll be reduced muscle and bone. There'll be increased fat mass. The person becomes obese. And then there is risk of cardiovascular diseases such as myocardial infarction, cardiomegaly, and such other diseases. The other diseases that you need to know about is that due to underproduction of luteinizing hormone and follicle-stimulating hormones in both males and females, in females we'll have amenorrhea. In males we'll have erectile dysfunction, that is denoted as ED, and in both we'll have infertility. That is just something that we need to appreciate: amenorrhea, erectile dysfunction, and infertility. And also we can also have thyroid stimulating hormone being underproduced, that is hypothyroidism, leading to hypometabolism. So remember, these hormones ideally enables, or they are central hormones because they enable production of other hormones by other glands. So for example, this thyroid stimulating hormone stimulates thyroid to produce thyroid hormones. So failure of or deficiency of thyroid stimulating hormone, you'll have hypothyroidism. And the function of the thyroid hormones is regulation of metabolism. So you'll have hypometabolism. So features such as fatigue, dyspnea will come across. Then for HCTH, ideally it enables production of cortisol in the adrenal glands. So that leads to central adrenal insufficiency. So central AI means central adrenal insufficiency. Also, if you have deficiency in production of prolactin, is a hormone that enables milk production in the mammary glands or in the breast. It will lead to deficiency in milk production. And then the other one is antidiuretic hormone in the posterior pituitary, which leads to diabetes insipidus. So that's about hypopituitarism. What about now hyperpituitarism? So for hyperpituitarism, the pathology itself is that there is overproduction. So in hypo, there was underproduction. In hyper, there is overproduction by hormones by adenohypophyseal cells or the cells of the anterior pituitary gland. But what leads to that most of the time is actually due to tumor cells. So tumor cells overproduce. So that leads to growth hormone secreting adenomas, leading to gigantism. The person becomes so big. If this growth hormone tumors occur in children, it will lead to the child developing gigantism, the child becoming very big. And if these adenomas occur in adults, they will lead to acromegaly. Other tumors that you can have is prolactinoma, leading to overproduction of breast milk, that is hyperprolactinemia. Then also you can have tumors that affect ACTH cells, leading to Cushing's disease. And we'll appreciate that. So ideally, what you'll be able to appreciate morphologically is that if you look at the pituitary tumor for a person who has hyperpituitarism, you'll appreciate there'll be a very big tumor, macroadenomas, usually called macroadenomas, pituitary macroadenomas. So due to that, the sella tussica, remember the sella tussica is a bed of this pituitary gland. So you'll have enlargement of sella tussica in large tumors, and you'll have compression of optic chiasma. Remember, I showed us earlier that the optic chiasma is superior to, as you can see here, superior to the pituitary gland. Now you have a tumor here. What will it do? It will compress the optic chiasma. And through that, now you'll have visual disturbances. Yeah, and you can see there now. You'll have acromegaly, so person with acromegaly has enlarged hands, enlarged jaw, soft tissues. Hyperprolactinemia leads to galactorrhea, amenorrhea, and such things. And due to the mass effects, the person will have headaches and bitemporal hemianopia. What about the thyroid glands? I'm sure you can actually touch your thyroid gland right now. It's found on the neck. Extends from C5 to T1, as you can see there. This is a thyroid gland. You can see it has two lobes and an isthmus at the center. So the right lobe, left lobe, and an isthmus connecting them. So where will you find this thyroid gland? One, you can see it's butterfly shaped. Looks like a butterfly, so it's butterfly shaped. Extending from C5 to T1, it has two lobes, and it's highly supplied, high vascular connection or high blood supply by the superior and inferior thyroid arteries. Superior and inferior thyroid arteries supply this. It's just a review of the anatomy. Then, of course, when you move, when you chew, when you rotate your neck, when you flex your neck, it moves with swallowing or maybe because it is attached to the larynx. And also this is the larynx. It's attached to the larynx by the pretracheal fascia. So in terms of histology, I'd like us to appreciate this. You can appreciate here. These are now the inferior thyroid arteries. These are the superior thyroid arteries in terms of blood supply. So what I'd like us to appreciate more is this. These are histological aspects. So if you can look at this image histologically, if you can look at the thyroid gland histologically, what will you be able to see? One, you'll be able to see thyroid follicles. You can see there is this inner structure here surrounded by cells. That's a thyroid follicle. So thyroid follicle is actually spherical structures. You can see this structure here. So spherical structures lined by simple cuboidal cells. And those simple cuboidal cells are follicular cells. And in the lumen of these thyroid follicles, will have colloid. As you can see, colloid containing follicle. And then on the periphery, you'll have these parafollicular cells. So follicular cells produce now the thyroid hormones known as T3 and T4. So it's good you appreciate what is T3 and T4. They are the thyroid hormones. And then parafollicular cells, these ones now on the periphery, they'll produce calcitonin. And this calcitonin is in charge of calcium regulation. So you can appreciate here just a simple anatomy of its thyroid hormones. You have T3, which is biologically active. T4 is one that is produced in greater quantity. So T4 is actually converted to T3. This is anatomy you can appreciate here. It's butterfly shaped, a very good image, just anterior to the larynx. And you can see the esophagus location. Histological, this is a thyroid follicle. You can appreciate the colloid and the follicular cells on the periphery. So we won't go through this image here and this other point here, but I like us to appreciate these two. So a thyroid hormones, we've talked about metabolism regulation. So for a person with thyroid hormones, you'll have synergism. So they allow growth of the body. Synergism with growth hormone. Number two, they increase tissue consumption, oxygen tissue consumption. That is, they encourage metabolism of protein, carbohydrates, and glucose. The other one, they increase cardiac output and ventilation, and they facilitate CNS maturation. So in an exam setting, I can tell you to list 4 functions or effects of thyroid hormones on tissues, and I'll expect you to mention these 4 functions here. Like using that the materials are always available. Then, so what are some thyroid? There are actually 2 thyroid hormones. Will have hypothyroidism, hyperthyroidism, and hypothyroidism by the name itself. So hyperthyroidism, overproduction of thyroid hormones. Hypothyroidism, underproduction of thyroid hormones. So you'll expect in a person with hyperthyroidism to have more of these effects here, and a person with hypo to have less of these effects here. And let's appreciate that. So you've talked about this hypothyroidism. So what are the causes of hypothyroidism? I would like us to appreciate them here. So the causes are 6. So 6 causes. I can give you in an exam setting, list causes of hypothyroidism. And one of them is called Hashimoto's thyroiditis. Hashimoto's thyroiditis. So Hashimoto's thyroiditis is actually chronic autoimmune thyroiditis or acute or chronic inflammation of the thyroid gland, which is autoimmune in nature. So the other one is you can if you give a person more drugs to treat hyperthyroid treatment, that will lead to hypothyroidism. So you're giving a person drugs to correct hyperthyroidism, and such drugs are such as surgery or radio. Okay, such treatments are surgery and radioactive iodine. They will lead to hypothyroidism. The other one is iodine deficiency. Iodine deficiency. Otherwise is inflammatory diseases. Inflammatory diseases such as subacute granulomatous thyroiditis. And then some of them are actually congenital. So congenital hypothyroidism, which is actually rare. Yes. So what are some of the features that the person will present? One, decreased BMR means body metabolism rate. Remember these thyroid hormones, they enabled increase in basal metabolic rate. So decrease in body metabolic rate, a person with hypothyroidism. So the person will have weight gain, the person will lose appetite, and the person might develop goiter. In terms of the skin, hair, and the face, the person will develop cold intolerance. As you can see in this image, the person is like holding his hands together because of the cold. Reduced sweating, so the person doesn't sweat. The person will appreciate cool, dry skin with edema, with or without edema. Then the person will have puffy face, as you can see in this image. And the eyelids will be somewhat like, as you can see here, and then hair loss. So you'll expect now a person with hyperthyroidism to have opposite of these effects, as we'll see. And you can appreciate the person can have myxedema madness and myxedema crisis. The cardiovascular and respiratory effects: decrease in heart rate and cardiac output, decrease in ventilatory responses. The person can easily get into depression, retarded speech, fatigue and lethargy, and such things. But for us, it's good to appreciate these features. What about now hyperthyroidism? Hyperthyroidism is opposite of hypo. And allow me to go through, first of all, the clinical features. The other person wasn't sweating. This one is increased sweating. The other person had cold skin in hypothyroidism. This person will have warm skin. Both of them will have hair loss. This one will have increased body metabolic rate. The other one had less metabolic rate. So the person will have increased appetite. The person will have weight loss. The other one had weight gain. Okay. Then this one will have lid retraction, as you can see, and the eyes will be projecting out. That is a condition known as proprosis. In cardiovascular effects in hypothyroidism, the person had decreased heart rate, cardiac output, and hypotension. So this person now will have, the person with hyperthyroidism will have increase in heart rate, increase in cardiac output, increase in hypertension, or hypertension ideally, and frequent bowel movements. This is a very good image trying to show us even the muscle tissues. And the person will develop tremors, as you can see. So the person will develop tremors, the person will become nervous, and increase in tendon reflexes. So due to actually increased overactive, this hypothyroidism means there is overactive thyroid gland. So it will lead to organ decompensation, that is thyroid storm. And that will present with now all those features that you can see there. GI effects such as nausea, vomiting, diarrhea. The person might also develop tachycardia, congestive heart failure, and atrial fibrillation. Just some of the symptoms. So in an exam setting, I can give you to compare or maybe to give the differences between hypothyroidism and hypothyroidism. And I would like you to define what is hypo and hyperthyroidism, and then give the clinical features. So causes, the other one had 6, this one will have 7. One, remember the other cause for the other one was the other cause of hypothyroidism was actually Hashimoto's. For this one, we'll have Graves' disease. Graves' disease will be present in hyperthyroidism. The other one was Hashimoto's. So this Graves' disease is where now you have autoimmune disease affecting the cells that are producing these hormones, now telling you to overproduce the thyroid hormones. The other one is that you can have toxic multinodular goiter. You can have tumors of the thyroid glands, solitary thyroid adenomas. Those are benign tumors. Then you'll have thyroiditis. Thyroiditis actually will lead, first of all, hyperthyroidism, then afterwards leads to hypothyroidism. Then it can lead to iodine-induced effects, iodine-induced hyperthyroidism, and also pregnancy. Pregnancy can also induce hyperthyroidism. So that's about hypothyroidism and hyperthyroidism. I would like us now to go to the next bit, which is now talking about the pancreas. This one we had already covered it in our last session. So it has four parts, actually five parts: the uncinate process, the head, the neck, the body, and the tail. It has two ducts. This is a major pancreatic duct of Wisang. This is a minor pancreatic duct. In terms of blood supply, we talked about it by the splenic artery and also superior and inferior pancreaticoduodenal arteries. And in terms of anatomy or histology, it has two parts. It has an exocrine pancreas and endocrine pancreas. So exocrine pancreas we covered last time by saying that it produces digestive enzymes. So we talk about pancreatic amylase, pancreatic lipase, and proteases are produced by exocrine pancreas. What about now endocrine pancreas that we talk about today? It produces B cells and beta cells and alpha cells. It has beta cells and alpha cells that produces insulin and glucagon. And that is what you can see here. So we have, this is a pancreas. This is the exocrine part of the pancreas, the one that is taking most steam. And then there is this. This is the endocrine part of the pancreas that you are seeing now. Yes. And then this is the exocrine pancreas. So today's part, we are going to measure on this alone. This islet that you can see here, this islet of Langerhans is the one that will be containing endocrine cells. And actually, no, a magnification of that is that it has about 4 or 5 cell types, and you can see them here. So these are the Langerhans, these are the islets of Langerhans, these ones. They're the islets of Langerhans. So these islets of Langerhans will have these cell types: alpha cells, beta cells, we'll have F cells, and these, so you'll have and the delta cells, sorry. So alpha cells produce glucagon, beta cells produce insulin, delta cells produce somatostatin, and F cells produce pancreatic polypeptides. And now this is a summary of what is a function of these cells. So glucagon increases blood glucose levels. Insulin now does the opposite of glucagon. So insulin reduces blood glucose levels. Glucagon increases blood glucose levels. Somatostatin inhibits production of insulin by beta cells, as you've seen here. And also it enables production of glucagon by the alpha cells. And then the other one, pancreatic polypeptide, has a role in appetite, as you can see there. So it regulates pancreatic endocrine and exocrine secretions. So in an exam setting, I can tell us to list cell types that are found and cell types that are found in the islets of Langerhans and give their function. So when I talk about that, I'll expect you to talk about alpha, beta cells, delta cells, F cells that actually produce the various hormones: glucagon, insulin, somatostatin, and pancreatic polypeptides in that regard. So our first thing that you're supposed to describe today is actually diabetes. So diabetes mellitus, remember you have two types of diabetes: diabetes mellitus and diabetes insipidus. And a diabetes mellitus is actually comes across due to deficiency of production of insulin. And we need to understand that diabetes mellitus is actually a pathology, is actually a metabolic disorder due to lack of insulin or deficiency of insulin secretion, or maybe it's not acting well, which produces hyperglycemia. So the person, if you have increased level of glucose because it's not being broken down into the tissues, the person will have hyperglycemia. So what are the types? The common types of diabetes is type 1 and type 2. So type 1 diabetes comes across when the person has pancreatic beta cell destruction. So this one happens in the tissue. So you see here, so these beta cells are completely destroyed. So there is no production of insulin. Or that is type 1. In type 2, insulin is being produced well by beta cells, but there is the tissues, they are not taking well insulin. That is insulin resistance. So you can see in this, in a healthy person, the pancreas produces insulin, the insulin is utilized in the body. In type 1, there is no production of insulin. That leads to issues with glucose uptake. In type 2, insulin is being produced by the beta cells, as you can see here, but now these tissues, they are not taking insulin. These tissues are not taking insulin. And now, due to the person presenting with features of hyperglycemia, because you have glucose in circulation, but the glucose is not being taken by the tissues, the person will present with these features, usually called the three important features is three P's. Three P's. So three P's. Polyuria, that is the person urinates a lot. Polydipsia, the person has dust a lot, as you can see here. So polyuria, increased urine output. Polydipsia, increased liquid intake. And polyphagia, the person has increased appetite, so increased food intake. So glycosuria, polyuria, polydipsia, and polyphagia, those are some of the commonest features of diabetes mellitus. This is a very good summary of what is diabetes mellitus. So a summary is that deficiency or lack of insulin production, which leads to hyperglycemia. So this hyperglycemia, it will give us two types of diabetes. Diabetes type 1 and diabetes type 2. Type 1, pancreatic beta cell destruction. Type 2, insulin resistance. What are some of the features? We saw actually what happens in this. Some of the features are majorly the three P's. So polyuria, the person urinates a lot, increased urine output. Polydipsia, the person takes a lot of fluids. And polyphagia, the person has increased appetite, as you can see here. Okay, so before we go to this, I'd like us to appreciate the complications of diabetes. And the complications of diabetes will be 1, diabetes ketoacidosis. The person nauseates, undergoes vomiting, fatigue, fruity breath, and such. The person also has vascular diseases, and the person has hypoglycemia. So that is it. If you are free, you can join me in the next 10 minutes. I want to give you a break of 10 minutes, then we'll be back so that we can continue. I'm 3 slides remaining actually, but I'd like to give us a break of 10 minutes. See you in a few. The image that you can see on our right shows us what we'll be describing as a healthy person produces insulin normally, and then glucose is being taken, and this enables the glucose to be taken into the tissues. In type 1 type of diabetes, the person cannot be able to produce glucose. The pancreas failure to produce insulin, and so the receptors are not stimulated to open for glucose intake. Then in type 2, there is production of insulin, but now there is a resistance in terms of insulin receptor that leads to no opening of of glucose intake into the body into the cells. So cells fail to respond to insulin intake in that regard. So I think we can continue. For the other image, I had showed us a few things regarding how this diabetes mellitus comes across. So this just to try and show us as like the function that comes across. So this diabetes mellitus is when there is increase in glucose intakes. So the three P's, symptoms of hypoglycemia, as you can see here, there is polyphagia, extreme hunger, there is polyuria, frequent urination, and polydipsia. That is extreme thirst. Extreme thirst. So that is what the person presents ideally. And there is symptoms of, as you can appreciate in this slide, is that in type 1, it's an autoimmune destruction of B cells. Remember, B cells are the one that produce insulin. In type 2, insulin secretion is normal, but there was insulin resistance. Yeah, and that leads to hyperglycemia. So hyperglycemia means elevated glucose in circulation. That leads to tissue cannot use glucose, and there is insulin absence or resistance. And this is just to show the pathophysiology that comes across. So just to make us understand how polyuria comes in, how polydipsia comes in, and polyphagia comes in. So appreciate polyphagia in here, polyuria in here, and polydipsia that comes across when there is all this happening. Remember, all this happen at the liver. Yes, all this is happening at the liver. Yeah, I think we can go now to the next slide, showing us the complications of this insulin, lack of insulin, or maybe lack of uptake of insulin. And I like us to appreciate these features here. And the features are, as we can see here, the three P's once again. There is glycosuria, there is polyuria, there is polydipsia, and there is polyphagia, as we talked about. And remember, we talked about the various subtypes, type 1, that comes across due to beta cells destruction, and the type 2, there is insulin resistance, as you can also appreciate there. So on this end, what we need to appreciate is that there are complications of diabetes. And the complications of diabetes is what is known as, 1, diabetic ketoacidosis. So in diabetic ketoacidosis, the person has nausea, the person has vomiting, the person has fatigue, the person has fruity odor, and the person has Kussmaul breathing that can lead to coma. The other one is the person might have smaller hyperglycemic syndrome. So this is a feature that has polyuria and deficient water intake. The person might have impaired growth and immune response and vascular diseases. Some of the features that the person can present. So in an exam setting, I just want you to know the signs and symptoms of hyperglycemia and these complications of diabetes. So it can lead to other additions that I'd like us to know is diabetic nephropathies. It can lead to loss of vision, actually, known as retinopathies, diabetic retinopathies, and also peripheral neuropathies. So diabetic nephropathies, issues with the kidney, diabetic nephropathies, diabetic neuropathies, or peripheral neuropathies that will come across due to this hyperglycemia. The other one is in the kidneys, diabetic nephropathies. In the eyes, diabetic retinopathies can come across. And also remember, people can have diabetic foot in that regard. So as I wrap up, just to show you this is the last gland of the session today, which is the adrenal gland. So you can appreciate these are the kidneys. This is a right kidney, this is a left kidney. So for the kidneys, I want us to appreciate that these kidneys, they will have structures above them, the suprarenal or the adrenal glands. Suprarenal or the adrenal glands. So you can appreciate these suprarenal glands are just above the kidneys in each of them. These are right suprarenal glands, the left suprarenal glands. And these suprarenal glands are the other ones that are also known as adrenal glands, also known as adrenal glands. So these adrenal glands, we need to appreciate. You can appreciate on this other end, these are the kidneys, these are pelvis of a person, kidneys in the body, right adrenal gland, left adrenal glands. So if you look at the histology of it, this is what you'll be able to appreciate. That this adrenal gland has three layers. It has zona glomerulosa, has zona fasciculata, and has zona reticularis. And then it has a medulla. So it has outer cortex and inner medulla. So outer cortex has three zones: zona glomerulosa, zona fasciculata, zona reticularis. And inner medulla has just blood vessels and various cell types. So maybe in an exam setting now you can be told to describe the histological organization of the adrenal gland. Will be expected to talk about. It has two major layers: the cortex, the adrenal cortex, and the adrenal medulla. The adrenal cortex has three zones: zona glomerulosa, zona fasciculata, and zona reticularis. So why do we need to learn about these layers? As you can see here, there's a kidney, it has a suprarenal gland above it. Suprarenal or the adrenal gland has the cortex and medulla. The cortex has zona glomerulosa, fasciculata, and reticularis. Maybe just to appreciate, this medulla will also have medullary veins in them, as we can see there. The other thing that we need to appreciate is actually this zona glomerulosa produces aldosterone. Aldosterone is concerned with salt regulation, or it's actually called mineral. It produces mineral corticoids. The zona fasciculata produces glucocorticoids, and one of the glucocorticoids is actually cortisol. And then the other one is, the last one is zona reticularis, or in the cortex. Remember the cortex has three layers: glomerulosa, fasciculata, and reticularis. For reticularis, it produces androgens. Androgens such as dihydroepiandrostenedione and androstenedione. So this dihydroepiandrostenedione and androstenedione are some of the androgens produced in both males and females. And then this medulla produces catecholamines. These catecholamines are either adrenaline and noradrenaline, or epinephrine or norepinephrine. Those are some of the, actually those are catecholamines. Catecholamines are two: epinephrine and norepinephrine, also known as adrenaline and noradrenaline. So those are the hormones produced by this adrenal gland. So on our last slide, to describe now this, maybe to remind you that we've talked about the anatomy. Maybe what I haven't talked about is the blood supply of this adrenal gland, supplied by inferior phrenic arteries that give superior suprarenal artery. Abdominal aorta gives middle suprarenal arteries, and then the renal arteries give inferior suprarenal arteries. But the whole point is we need to appreciate the histological aspect. So as you can see, the capsule, it has a capsule, then the cortex has zona glomerulosa, fasciculata, and reticularis. Glomerulosa produces aldosterone that enables salt balance. Fasciculata produces cortisol or glucocorticoids for sugar balance. And then zona reticularis produces androgens for sex. And then medulla produces norepinephrine and epinephrine. And you can see now the histological organization there. And this norepinephrine and epinephrine is what you're calling catecholamines here. So if we talk about production of that, if you have now issues with production of those hormones, what will you have? You will have what is known as Cushing's. Remember, you can have you can have Cushing's disease or Cushing's syndrome. Cortisol physiology that we can have here is that we can have production of hypothalamus, which produces corticosteroid releasing hormone. This corticosteroid releasing hormone comes to the pituitary gland, enables it to produce ACTH. Remember, ACTH is what we called adrenocorticotropin hormone, which stimulates adrenal cortex produce cortisol. Cortisol that is produced in zona fasciculata. Then cortisol travels bound to the plasma proteins and enables these functions here. So the functions of cortisol in regards to glucose metabolism is that it has immune functions, inflammatory functions, and metabolic functions, as you can read them there. So if you have now failure of these cortisol effects, which is it suppresses inflammatory and immune responses, leads to carbohydrate metabolism, such as increased gluconeogenesis, increased insulin resistance, and decreased insulin utilization. It also leads to protein metabolism, that is breakdown of proteins. It leads to fat metabolism, leading to lipolysis and adipose cell hyperplasia. It also leads to bone remodeling, leading to increased bone resorption. So what will be now features of hypercortisolism? And this hypercortisolism is what is known as Cushing syndrome. And the person will have features as shown by this. So the features will be: one, hyperglycemia. Why? Because of increased gluconeogenesis and increased insulin resistance. So hyperglycemia. So the person will have features of diabetes. Two, immunosuppression. Why? Because this cortisol suppresses immune responses. Three, the person will have hypertension, that is increased blood pressure, because of its effects on the cardiovascular system. The other one is, given that it leads to fat metabolism, lipolysis, it will lead to fat accumulation and redistribution. So the person will have moon facies, that is moon-faced. The eye looks like it's moon-shaped, as you can see here. The other one is buffalo hump. So the person has a buffalo hump. The other one is central obesity. So this is central obesity because of fat accumulation in the peritoneal cavity, at the back, and also in the face. The person will have muscle weakness, skin weakness, as you can see in this. The person can turn into depression and anxiety, and also there is menstrual irregularities, amenorrhea, and there is impaired growth in children. So that is what we refer as this is what we can also try to describe in terms of hypercortisolism. Like there is excess production of cortisol. So if there is excess production of cortisol, there is now increased effects of cortisol, and that leads to such features, as you can see here. And that now will lead to this image that we can see here, the Cushing's disease or the syndrome symptoms. So the personality changes, we talked about depression, anxiety kicking in. The person will have flat round red face, that is the moon face. The person will have buffalo hump, at the back, the person will have gynecomastia and amenorrhea. There is fat deposition leading to central obesity, as we talked about buffalo hump and central obesity. Remember, the muscle will undergo weakness, leading to osteoporosis and increased risk of fractures. So the bones and the skin will undergo weakening, leading to osteoporosis, increased risk of fractures, and also purple striae. Due to the weakness on the skin, lead to thin skin and also bruises and petechiae. In females, the person will have hirsutism and amenorrhea. Yeah, so that's it regarding Cushing's disease. The symptoms, they are that. So in an exam setting, I can tell you to describe features of hypercortisolism. And these features of hypercortisolism is actually Cushing's syndrome. And this Cushing syndrome now will give us excess effects of cortisol that will present as seen here. And this image describes them very, very well. So that's it for today's session. But maybe before we leave the session, we need to appreciate that